All right, welcome back, everyone. Let's go ahead and make our way back to our seats. Hopefully everybody is feeling refreshed after that really great session on gene therapy and your short break. We're going to shift gears for this next session. I'm really excited. We had some really engaging conversations at the Duchenne Healthcare Professionals Summit earlier this year in Sanibel Island, which is our annual healthcare meeting, where we kind of started to explore the interaction of sleep and behavior and how the two influence and interact with one another, and how we can think about care for sleep and care for behavior and optimizing both the quality of care that individuals are receiving as well as quality of life. So I am really, really looking forward to this session. And with that, I am going to introduce Dr. Richard Kravitz, who is a pediatric pulmonologist at University of Virginia, and he will be just taking us through this next hour or so conversation. Dr. Kravitz?
Thank you. Thank you all for having us here today. We're very excited about this talk. You know, we've done a great job of talking about how the respiratory components of muscular dystrophy can impact on your breathing and your sleep. And we've done a great job over the years of explaining the needs for BiPAP and non-invasive ventilation and even tracheostomy, mechanical ventilation. But we really haven't talked about sleep as a whole. And that's just one small component of it. What we're going to do today is do a 360 on sleep. And we're going to go through a lot of slides to start, where each of us are going to speak for about 5 minutes, kind of lay out the landscape of sleep. And then we're going to use the second half of this hour to go with questions. And based on the feedback I've been getting from sessions, I suspect long lines are going to be going to the microphones today because there's a lot of questions. But I think this talk is really great is because our boys, our young men are living long enough and living well enough that really having a good night's sleep is becoming more and more important. It's just not about keeping their ventilatory supports alive. It's about their sleep. And speaking to all the parents in the room, you guys are wonderful caregivers. You do a great job of keeping your boys happy and healthy and helping them reach their potential. But if they don't have a good night's sleep, that's a limitation to their reaching their potential. And if they don't have a good night's sleep, as you all know, you don't have a good night's sleep. And if parents don't have a good night's sleep, they can't be the caregivers they want to be. So a lot of the things we're going to talk about is not just helping your sons, but your family too. So as a quick introduction, again, my name is Rich Kravitz. I'm a pediatric pulmonologist and sleep physician at the University of Virginia. We're just going to go down the line for our speakers, and they'll reintroduce themselves when they start their part of the talk.
Thanks, Dr. Kravitz. I'm Lauren Treat. I am a child neurologist and palliative medicine doctor at the University of Colorado, Children's Hospital, Colorado.
I'm Natalie Truba. I'm a pediatric psychologist at Nationwide Children's Hospital in Columbus.
Hi, I'm Elizabeth Margolis. I am a child and adolescent psychiatrist, also from the University of Colorado at the Children's Hospital, Colorado.
I'm Claudia Senesac from the University of Florida. I'm a physical therapist and clinical professor at the university.
Great. Well, thank you guys for coming and joining me on the stage and doing this. I think we're going to have a really robust set of discussions today. So we're going to start off with an oldie but a goodie, and that's the pulmonary impact on sleep. Because if you don't have good pulmonary care and good control, then all the other sleep problems are going to become harder to manage. So there we go. So as you all well know, there's a progression in respiratory muscle weakness. Our boys start out with reasonably good strength. They have normal coughs. They sleep in terms of their ventilation and airway patency. Everything's pretty normal. But as they start getting weaker, their coughs become weaker, and they're at risk for inadequate coughing. Soon after that develops is they start having nighttime sleep-related issues from their muscle weakness. It first appears in REM, or rapid eye movement, or dream sleep. It eventually affects the entire night's sleep. And ultimately, when the respiratory weakness gets severe enough, they have both breathing problems day and night. We're going to focus a lot on topic number 3, the nocturnal symptoms, and when we start using nocturnal bilevel or ventilator support. So sleep disordered breathing. What are our goals for ventilatory management? Well, when you're muscle weak, not just in your chest wall muscles and your diaphragm, but your airway muscles become weak. And when they collapse on themselves, you can start having upper airway obstruction, or classic symptoms of obstructive sleep apnea. So obstructive sleep apnea is not just a condition for middle-aged, obese men. We see it in children all the time, usually from big tonsils and adenoids, but for our neuromuscular patients, it can be from upper airway collapse. When you are muscle weak, you can take more shallow breaths, and that can lead to oxygen desaturations and or carbon dioxide elevations. And whether you have obstructive sleep apnea or hypoventilation, any of these can impair the quality and quantity of the sleep you have. Sleep also serves a lot of other functions. It allows for respiratory muscle rest and kind of regain some of the energy that they've used up during the day with regular daily breathing. Excuse me. We want to have good chest wall excursion. We want the chest wall to be fully inflated. Like at night, we all hypoventilate while we're asleep, but if we have muscle weakness, that hypoventilation can be worse. Our lung volumes can get smaller, our oxygens can drop more, our CO2s can go higher. So we want to have good chest wall excursion while we're asleep. We want to compensate when our kids have colds. When they get colds, they get weaker. When they get weaker, they have more weakened cough and more sleep disorder problems. So we want to make sure we give them support when they're ill. And all this is really in the end of optimizing their quality of life. We want them to be comfortable, we want them to be well rested so they can reach their full potential. So when do we initiate respiratory support? Well, there's no hard and fast number on that. And there's some kids who need support early in their lives and others that need it later. You take each individual child and family for what they present with. But some benchmarks that we look at is your forced vital capacity in their spirometry maneuvers. If it's less than 50 to 6% of predicted, that's a sign that you're going to be at risk. And I picked up a lot of kids on their PFTs where I did a sleep study, even though they were asymptomatic, but their sleep studies showed abnormalities. That told me that we maybe need to initiate care sooner than we might otherwise be expected to. We look for oxygen saturations. If they're low while they're awake, if they're low while they're asleep, that's a sign they might need nighttime support. Same goes for CO2 levels. When they're elevated, it's a sign they might not be taking deep enough breaths and need help at night. We usually make the initiation of bilevel or non-invasive therapy with a baseline sleep study. When you get a sleep study, you go to a sleep lab, and I will emphasize that the sleep lab really needs to be a lab that is comfortable doing neuromuscular patients. Our young boys, whether they be children, teenagers, or young men, really cannot get home sleep studies. It just doesn't do give us the full amount of data that we need. So these have to be in hospital, not inpatient, but in hospital-based labs, and we always need to measure CO2. A lot of adult labs don't measure carbon dioxide level. You want to make sure you're going to be looking at all parameters of the sleep. And we look for obstructive sleep apnea, hypoventilation with low O2s and or high CO2s. We look for desynchronous breathing, fast breathing, and what we call frequent arousals are really disrupted sleep. Then all these things can lead to poor sleep quality and a non-restful night. Recurrent infections can also be a sign that they're having hypoventilation at night, and is also an indication for a sleep study and further evaluation. Basically, we're looking for anything to suggest sleep dysfunction. And some of the questions listed below are things I'll ask families about. And one of the biggest tools I'll ask is do they fall asleep in the car when they're going for long distances? That's not so abnormal because most teenagers are sleep deprived. But if you have a young child falling asleep frequently in the car, that's not normal. If they can fall asleep on the school bus, you all can remember back when you rode the school bus, nobody sleeps on the bus. If they fall asleep in bus, they're falling asleep in class, that's a sign they're having sleep dysfunction and further assessment needs to be done. These are just some of the modes. We have non-invasive ventilation. We have invasive ventilation with the tracheostomy. We have BiPAP machines here you see on the lower left. And then we have various ventilators. These are all pumps. Which one you get really is dependent on what's available in your community and what your child's needs are. There's various interfaces. I put up a picture of the WISP, which is a common mask we use in young children. And the young gentleman on the lower right, he has a tracheostomy tube, and the trach never slowed him down. He just kept on going. So we have lots of different ways of getting the support you need. So what are the takeaways from this? From a respiratory muscle perspective, we want to assess your sleep to make sure you're having good quality sleep that is not being disrupted by airway obstruction or hypoventilation. So we want to treat the obstructive sleep apnea if it's present. We want to treat the hypoventilation if it's present. There's lots of different ways to treat them, and there's as many ways to treat them as there are families and patients, so we pick the right therapy for the right child at the right time. And with these proper interventions, there is no reason why the child can't have a good night's sleep from a physiologic perspective. Then there's all the other behavioral components, which my colleagues here are going to be passing the baton to. So I am now going to just remind you, anything is possible. We're only limited by our imaginations. And you guys are wonderful caregivers. You really put it on the line for your kids. Our job is to help you succeed at what you're trying to accomplish as a family. So I will still wait for them to transition to the next slide. Yep. And our next speaker will take over. Here you go.
Okay, thank you guys. Again, for those who came in the room late, I'm Lauren Treat. I'm a neurologist and pediatric palliative medicine doctor in Colorado. And I'm going to talk about sleep and behavior from where my neuro hat goes on with the neurology of sleep, but also when people hear palliative medicine, they might have a little bit of pause about how that fits in up here. I'll just take a brief moment to say that palliative medicine in this context and really broadly is not focused on end of life. A lot of people get nervous when they hear palliative medicine, but really palliative medicine currently is trying to understand how we think about quality of life at any phase of illness. And as Dr. Kravitz already mentioned, sleep is a big part of that. We take sleep for granted often when it's going well, and then when it's not going well, it can make you feel really crazy and really not like yourself. And so that palliative medicine lens is trying to help people say, how can we feel as much like ourselves as possible in the body that might be complicated? So we'll get into this here. The neurology of sleep, I think people can appreciate that the brain is very, very intricately involved in regulating your sleep. A lot of what I think about is trying to strike the right balance, and the brain is always trying to strike the right balance, especially when it comes to sleep. We don't want to sleep too much, and we also don't want to sleep too little, and so the brain is constantly taking in all of this information to try to regulate the right amount of alertness at the right time and the right amount of rest at the right time so that we can regenerate and be ready to be alert again. And so this fine balance is really going on all the time in the brain, and we have to kind of step back and appreciate what conscious and also what unconscious signals we're feeding into our brain so that we can get the right amount of sleep. And especially in a world that's full of bright lights, bright screens, bright shiny objects, sometimes that unconscious messaging can be a little bit more tricky than we realize. So this is where we really need to focus. We know there are scientific studies. One of the pictures that I have here is about how poor sleep actually changes brain chemistry, changes brain structures. This study here is from a study of adolescents who had chronically poor sleep, and they saw that their brain had lower volumes in some specific regions over time. And so in case you needed an extra reason to be motivated to think about sleep in these ways, we need to definitely focus on it for both the day-to-day benefit, but also our long-term benefit. We also know that people who have poor sleep are likely to also have low mood and also have changes in their ability to modulate things like pain. If you don't have good sleep, you're not going to have all your faculties, all your resources. You're not going to have your ability to pay attention in school, but also pay attention to the other things in your life that might help you cope with some of the challenges that are going on or maybe the pain that you're experiencing. So we need that sleep for all of those reasons. Let's take a moment real quick to just define some of these terms that we're throwing around. You hear this insomnia term a lot, and really from a technical standpoint, what we're describing is someone who's having difficulty either going to sleep or staying asleep. We kind of lump into there some things, problems with early awakening and subjective problems, ways that you get sleep through the night but maybe don't feel rested in the morning. And when it becomes a diagnosable problem is really when it's persistent. It's not just an every once in a while problem, and then also gets in the way of the things that you're trying to do day to day. So that diagnosable insomnia problem consists of those kinds of things. And then I lump kind of the risk factors into these bigger buckets here. And again, thinking from a neurobiology standpoint, but also a quality of life, striking the right balance standpoint. People need to have their environment set up the right way to be able to be cued towards sleep, and we'll talk a little bit more about that. People also have risk factors when it comes to their medical regimen. If they're on stimulants, sometimes the steroid question comes up about how much steroid and when are we dosing that steroid, and is that getting in the way of our sleep? And then we talked about some of those environmental, unconscious or subconscious cues too. How do we think about those, and how should we moderate those in order to get that good sleep that we're looking for? That's your brain taking in messages. We also have to recognize that our brain can put out messages. We have control over some of these things to help retrain. And again, a lot of our talk today during this hour is going to be about those sorts of things. So this is going to be kind of a handoff towards trying to help think about what our thoughts and behaviors around sleep are like and how we can impact those. And then also how we can make our environment work for us. We know that medications have their role. We'll hear about that a little bit too. But that's my quick overview. Oh, I'm missing a word there. The brain is key to sleep. And so this is my summary slide. Poor sleep negatively impacts brain function, and the brain can also be really integral in helping to combat poor sleep. So I'll hand it over to Dr. Truba next. Thank you.
Hello, good afternoon. I'm Natalie. Again, I'm a pediatric psychologist for those of you who are straggled in a little bit late, but welcome. I'm going to talk about sleep and behavior as well from a little bit different perspective and go into some of the recommendations at the end and how you would maybe think about that or approach those. So as we all know, sleep is incredibly important for health, and there's a lot of different ways that we can think about sleep dysfunction, right? We can think about it, how efficient is our sleep? Are we getting good sleep at night? Are we having sleep difficulties, falling asleep, staying asleep? Do we have daytime arousal issues where maybe it looks like we're sleeping at night, but then during the day we're seeing these things that Dr. Kravitz and Dr. Treat were talking about, where we're having a lot more sleepiness and a harder time staying awake, attention issues. And these things actually sort of breed each other, right? So when you start to get into a cycle of sleep dysfunction, it can get hard to get out of it. And we know that good sleep is associated with a lot of improvements in things that are really important, like attention and concentration, general mood, emotional behavioral functioning, learning and memory, and just cognitive performance in general, as Dr. Treat was just talking about, and quality of life. And what we know is the youth are not getting enough sleep. And this isn't just kids with DBMD, this is just general. So 6 out of 10 middle schoolers, 7 out of 10 high schoolers are not getting enough sleep. That is alarming, especially when we think that our kiddos 6 to 12, we're trying to aim for 9 to 12 hours of sleep, and our kiddos older than that, we're going for 8 to 10. And then we have to think about how does a neuromuscular disorder that is characterized by weakness and fatigue factor into sleep. The other things that we have to be very careful of is the way that sleep impacts the brain, as Dr. Treat was talking about, and it reduces sort of how your brain functions in really important ways. The brain is a great system, but it's a fragile system at times too, and when you're tired, certain areas get really reduced, and particularly in our executive control areas. And this could lead to things like increased injury risk, which for our boys is really, really important, that we're optimizing our safety on our feet. And that's just true for any kid. So if you're not sleeping as well, you're a little bit more behaviorally dysregulated, you're a little bit more, your attention's decreased, you're not maybe picking up on the environment as well, and you're more likely to make a misstep that causes injury. In that same vein, for our youth that are adolescents, what we see is a reduced impact on sort of emotion regulation, distress tolerance, and using adaptive coping strategies to help us sort of manage really difficult internal experiences. And then we start to run the risks of really, intense sort of behavioral responses that include things like self-harm or suicidality. So we know that poor sleep is a risk factor for these things outside of DBMD, and I don't think it would be any different for our men and boys. Physically, sleep is really important because it helps our body function. These are all things that we very much worry about in our men and our boys a lot of times. And when we think about the bidirectional way that mental and physical health impact each other, we should start to be very worried if we're not getting good sleep, not only just from our quality of life and how our brain is functioning, but from how is this impacting my neuromuscular disease. Sleep concerns are really commonly reported in clinic. In our clinic, I know in y'all's clinic, really commonly reported. And sleep, we all know it. It's something we all do. So we're like, oh yeah, sleep. But sleep is an incredibly complex process that we are learning about now. And we know even less about it in DBMD. So there's been a couple studies in families with Duchenne. One of these studies looked at parent report and actigraphy data, which is what some of the PTs were talking about yesterday. And what these researchers saw is validating in the sense that the parent report data was consistent with the actigraphy data, and what they saw is lower sleep percent efficiency, which means we're not sleeping well, right? We might be asleep, right? So when people ask you, like, how's your kids sleep? And you're like, oh, they sleep really good. They look like they're sleeping. That doesn't necessarily mean we're getting good sleep. It doesn't mean our sleep architecture is good. We see more nighttime awakenings in this population, and their nighttime awakenings are longer. So when we are asleep, we're not getting good sleep. And are not getting good sleep, we're waking up often, and we're staying awake a long period of time. If you think about that, that's a lot of sleep disruption in one night and over time. Another study looked at this in relation to caregivers, and this is really important, and I wanted to include it because exactly what Dr. Kravitz was talking about is that nothing is happening in a vacuum, and none of you all are doing this independent of yourselves in relation to your kids. So they looked at actually sleep in relation to disease progression. They reported 60 to 80% of their sample reported sleep dysfunction in the DBMD group. What they saw was that sleep dysfunction did increase in parallel to loss of gross motor function, which I think we could all agree with. But the important part from this is that what we also see is as the sleep disturbance increased, it also had a negative impact on maternal caregivers, sleepiness during the day, and general sleep quality. So now if we think about all those health issues we've been talking about for where you're not getting good sleep, that applies to you all as well, right? And your own health, and if you're a carrier, and your own attention and your own safety behaviors. So you can quickly see how poor sleep impacted a family unit can have some really devastating consequences over time. And then I'm not going to go into this because Dr. Kravitz talked about it, but then you have then on top of that disease progression, and now we have another factor impacting sleep above and beyond just maybe things going on from a DBMD lens that makes sleep hard. So what do we do? Well, the first thing is if you're noticing changes in emotional behavioral functioning, mood, the first thing that you want to say is we need to look at sleep. This is a really big canary in the coal mine for sleep-related issues, and even if you have a young child, it's still worthwhile pursuing exploration into sleep because we do see that. We have to prioritize getting good sleep, not just for ourselves, for our kids, for your non-affected kids, siblings. Like sleep is really something that we're not doing a good job at right now as humans. There are several really helpful interventions for sleep. Behavioral sleep training focuses on training you in relation to stimulus. So if you all can remember sleep training your children, right? They were chaotic sleepers, and you put them on a schedule, and you slowly shape that schedule up. And sleep training can be very similar to that. It's reordering how your brain contacts the stimulus in the environment that tells it, okay, we're going to bed. And this is why things like screens and other things are really important to manage. And also spending time in your bed, if you're in your bed, and this can be hard for our guys who spend a lot of time in bed, and you associate your bed with all these other things like playing video games and eating and talking to people, you're training your body not to sleep in bed. And so we have to train sometimes to rewire that brain if we get really off, as Dr. Treat was talking, to actually perceive and attend unconsciously to the stimulus that tell your brain, oh, it's time to go to bed. And so that's where sleep training kind of comes in behavioral sleep training. Relaxation training can be really important, especially for our guys who are a little bit more dysregulated. If you're not able to calm before you go to bed, it's going to be really hard for you to fall asleep. So sometimes learning how do we do that can be really important through biofeedback, cognitive behavioral therapy. But then for those who have maybe more persistent sleep issues, multi-component cognitive behavioral therapy for insomnia is really effective. And it comes with brief treatment models that can be kind of tailored for maybe kiddos who have maybe not full diagnostic sort of insomnia where we're seeing really, really severe things, but maybe we can in 4 or 5 sessions sort of target aspects of the cognitive behavioral pieces that are maintaining that sleep dysfunction while we are working on retraining you from a behavioral standpoint. Thank you so much.
Hello again, my name is Elizabeth Margolis. I'm a child and adolescent psychiatrist from Children's Hospital, Colorado, and I specialize in working with kiddos who have intellectual and developmental disabilities. And so today I'll be talking about management of sleep with muscular dystrophy, nothing to disclose. And so, in kind of this brief couple minutes that I speak to you, really the big things that we're going to focus on are, talking about some of the psychiatric comorbidities that come with insomnia and understand when to consider medications. Obviously, we review appropriate medications for insomnia and muscular dystrophy, and then hopefully you'll gain a little bit of comfort in either utilizing these as a provider, or if they're for you or for your child, you'll feel more comfortable when they're prescribed. And so when do we use psychotropics to address sleep? And so, the big things are really when daytime drowsiness is impairing a function, and so that's what, everyone before me has already focused on a little bit. Other things include unsafe behaviors at nighttime, when we have quality of life impacts, and then when a psychiatric comorbidity is present. And I do want to say, when we're considering our medications, an important thing to remember is that the most important thing is characterizing the sleep and understanding where that struggle is. And so, are we having trouble sleeping because we're having racing thoughts and we're anxious? And that will put you down one pathway in determining what medication you're going to use, versus are we having trouble falling asleep, staying asleep? All of these little nuanced things can be really important when you're trying to pick out the medication that's going to be most helpful. And so, for example, no matter how much sedative medication we throw at a patient, if they are struggling with anxiety and we're not treating the anxiety, we're probably not going to get very far with the medications. And especially in a group of people who are on other medications, you really want to limit polypharmacy, because that in itself can make sleep more difficult. And so that kind of initial diagnosis of why aren't we sleeping is probably the most important thing that you're going to do when you're figuring out what's going on, maybe even more important than the medication you're picking. The literature in this area is very limited, and so if you do a Google search or anything like that, and you look at, specific to this group of individuals, what medications can we use for sleep, you might find next to, really no significant trials or anything like that. We do know there's certain groups of medication that can be helpful. This includes our alpha agonists, our tricyclic antidepressants, SSRIs, and then other agents like agents that are stimulants for the day if we're having a lot of daytime sleepiness. Rather than throw a bunch of alphabet soup at you, I'm happy to answer any questions about specific medications, and these are kind of more broad groups. And then how do we titrate and adjust, right? So yes, figuring out what medication is part of that battle, and how do we utilize our medications, but then almost just as important is how do we adjust them, right? We start a medication, why isn't it working, what do we do? And so there's a couple main tenets that I really recommend providers to stand by, and then families or patients themselves as advocates to kind of utilize when they're going on medication with their doctors. And with all psychotropics, not just sleep psychotropics, I recommend starting very low, increasing very slowly, optimizing things before you sort of, one, discontinue things, and then also discontinue medications that aren't working. And so we know that with every medication, there are side effects. Of course, you hope that a sleep agent isn't gonna lead to more wakefulness, but regardless, any limit of polypharmacy is important. And so if medications aren't working, it's really, really, really important to pull them off rather than add new medications on top. And so just some key takeaways. General idea is really when quality of life is affected and we think a medication could be helpful, that's the time to start one. You always want to consider a comorbidity that will help guide your medication choice. When you do choose a medication, you want to start low, titrate slowly, and then be really careful of polypharmacy. And then we'll save questions for the end. Thank you.
Hi, I'm Claudia Senesac, and I'm a physical therapist from the University of Florida. Okay, so typically we don't get referrals for physical therapy for sleeping disorders. But for us, during therapy, we might have behavioral problems, and that often leads to questions about sleep. So sleeping is really more than just closing your eyes. It does allow your muscles to rest, and there's some rejuvenation that happens there. It's rest for your brain. It rejuvenates the spirit, and it really helps to breathe like some fresh air into the house when everyone is sleeping and everyone's getting a good night's rest. Then the day sort of starts on the right foot. So sleep's really important, as you've been hearing. I just made a list here of things to consider. If I'm seeing a child and they have a behavioral problem during therapy, and it's really common, it happens a lot. They may not want to be there. They may not want to cooperate. There could be a number of reasons why there might be a behavioral problem. But often sleep, the topic of sleep often comes up. And these are some of the things that I want to know about if I'm talking to a parent about sleep. What position does your child sleep in? What kind of a bed are they sleeping in? What is the mattress like? Do they have a pillow? Do they sleep with a pillow? Are they sleeping with multiple pillows? Is it a foam pillow, a feather pillow? And then what are the other things in the bed? Because a lot of kids have a lot of things in the bed. It could be stuffed animals, it could be electronics, it could be a number of things that are crowded in to the bed besides just the child. It might be an animal, too. What's their activity level like? Are they overactive during the day, or are they not getting enough exercise during the day? What's the routine like? Do you have a bedtime routine? Is there something that the child expects to happen at a certain time in the evening that indicates we're getting ready for bed now? And what does it look like? And it might be something like, dinner's at a certain time, we do X, Y, and Z, and then we're actually, maybe we take a shower or a bath, and then we end up in pajamas, then we're in the bedroom, maybe we do some stretching, then maybe we read a book. It could be any number of routines, but is there some expectation that the child has that we're getting ready for bedtime, and there's like this winding down that happens so that they're expecting that there's going to be some rest involved here. And people get out of routines. You could have a wonderful routine and then something happens, which happens to all of us, where the routine is broken up for a few days, and that can throw the sleep pattern completely off. Do you do some type of massage at night with your child that can be very relaxing and just help tone everything down? What about food? Are you eating late? Is it a heavy meal? How does that work in terms of your meal time? What about fluids? Are they getting enough water? Are they hydrated during the day? But then do you start to taper that off at night so that they can actually sleep through the night and not have to be tossing and turning because maybe they have to go to the bathroom at night? What about pain? A lot of kids with Duchenne and with Becker and adults will have some type of pain or uncomfortableness. Can we address that? Can we do some positioning? Can we do maybe some other type of intervention that can relieve that so that they're more comfortable at night? What about the environment that they're in? What about their room? Can we make it more aesthetic for sleeping? Is it really brightly lit? Is the door open? Is there noise coming in from the living room? Is the hallway light on? Are the curtains open? Are they shut? Everyone has that special thing that their child likes when they're getting ready to go to sleep. I need the light on. I don't need the light on. I want the door open just a crack. What is that? And is it keeping them awake? And then what about the lighting? The lighting can make a big difference in whether or not your child's going to sleep through the night. The noise level. Do they have music on while they're trying to go to sleep? Do they have ear pods in and they're listening to something as they're going to sleep? What is it that they're listening to while they're trying to go to sleep? And then, of course, computer time and gaming time. There is some research out there that says you really should turn off that computer at least 30 minutes to an hour before the bedtime so that your brain has a chance to just calm down from this stimulating environment that the computer, the bright light of the computer, the blue light from the computer, and gaming, where there's this fast environment happening in front of us, and it's happening all the time. We're a very electronic society. So these are just some things to think about when we're thinking about sleep, but also thinking about behavior and how the lack of sleep influences the behavior of not just our children, but our own behavior as we're trying to deal with children that don't get enough sleep, or because we're not getting sleep either because we're dealing with them. So I'm going to leave it right there and take some questions.
All right, so thank you. Each of these 5 talks has been an overview. We could each spoken at least an hour on each of our topics, if not more. But I think we've approached sleep from multiple different perspectives. So we want to throw the rest of our time here open to family questions. But while people are potentially coming to the microphone, I'm going to say 2 things. This is the #1 evil tool of impacting on sleep. Okay? You should not let your boys with Duchenne do things that your children who are not affected have. So your child with Duchenne, unless you're using the iPhone as a way to communicate with the parents in a different bedroom, if your other children shouldn't be playing games before they go to bed, your Duchenne child should not be playing beds. This interferes with more kids. And as a sleep doc, the first thing I always say is, do they go to bed with their iPhone? And when the answer is yes, I go, well, you're going to have to take that away. And then I see the parents with the crestfallen face. And I'm sure you all see that too. But we need to make sure that what Claudia was saying is we need to set up the environment for a good night's sleep so that they can have good respiratory rest, good psychiatric care, minimize their need for medication, keep them comfortable. And now we have people at the microphone, so I don't even have to throw out a fake question. Please.
Hi, thanks, and you can stay there. So I don't know if you remember us, you saw us at Duke right before you left. So thanks for leaving. But anyway, my son is 22, and he goes to sleep really easily. He wears his BiPAP religiously. We have a little bit of a routine. Some nights it's more in the neighborhood of 30 minutes. Some nights it's in the neighborhood of 10 minutes. It depends on what's going on that night. And he, on a good night, he will have me up 3 to 4 times in a night. On a bad night, I don't even get 30 minutes of sleep before he's calling me again. Well, sometimes it's 5, but to come move me, come roll me, come do whatever. So in our last visit at our clinic, there was a long discussion about it and decided that it was potentially, he has low back pain is what he said. Well, he doesn't complain about that. I don't ever hear him say that. And so, but okay, so they put him on a muscle relaxer. That made no difference whatsoever. We're on melatonin. And his quality of life is being affected because mine is. So, I mean, he doesn't seem, I guarantee you, every one of you, I've heard you've talked to him, and I know Claudia's talked to him, and he probably knows half the people in this room. So he's just a little social butterfly. So goes and goes all day long with no problem, and, you know, goes to bed and goes to sleep. And I was told by a different clinician earlier today in the hallway that Natalie may have some information about certain mutations that might affect sleep. And I'm assuming, they said Natalie, so I'm assuming you. I don't know that there's any other Natalies here who are doctors, but you're looking like, I don't know anything about that, so it may not be you. So Dr. Kravitz, any thoughts? And Natalie?
I'm going to say a couple things first, and then I'll pass it off to Natalie. So the good news is your child, your young man, does not have difficulty initiating sleep. So that is a big issue, especially for younger children. So he's able to fall asleep. He's just not able to have maintenance of sleep.
Correct.
And one question I always ask my families when I'm doing my history is, how many times a night do you wake up? And when I look for two things. How many times is their baseline as it's going up? So you said it was 3 to 4 times, now it's 5, 6 or more. The two things that jump to my mind are they being adequately ventilated at night? Does his BiPAP settings need to be adjusted because maybe as he's going into REM sleep cycles, those pressures that were initially set are no longer adequate and he needs an adjustment in his support?
And we have checked those, and we have another sleep study scheduled.
There you go. But then moving on to point B is, what other things could be addressing? Like when I was at Duke, this is the exact time I'd bring Laura Case in to come and help me. What's going on with their sleep? Are they comfortable? What's the bed situation? But then, are there other things that are arousing him from sleep that are impacting on his sleep quality? And I will pass the microphone to Natalie.
So not based on mutation. However, we do see this in our population, and this is where cognitive behavioral therapy can be really helpful, because the way that the Duchenne-Becker brain works, and the way physiology and the way that they can get very perseverative or kind of stuck in places, and very hyper-focused on sensory experiences, and that can become a feedback loop. If you've heard me talk, I use a sock example a lot, because that's one that people hit a lot, and people are like, it takes me like 4 hours to put my kids' socks on. The more that we get into a place where we're focusing on comfort, discomfort, the more that we kind of maintain that. And we can actually train our brain and bodies to maintain a stimulus sort of response that is no longer recurring. And so if he is somebody that deals with a lot of discomfort, what can happen if he's waking up and saying, can you push me here, can you comfort me here, can you comfort me here? It likely is not maybe getting great sleep, not going in all the way to sleep, waking kind of suddenly, and then very focused on the sensory process of his body, which is totally fair, right, when you need those help. Therapy could be very helpful with that, with sort of helping him retrain, okay, how can I orient to this? How can I talk to myself about what I'm experiencing? Is it discomfort? Can I wait? Can I do something else to try to reinitiate sleep before I call for my mom? And so it doesn't necessarily address, the underlying organic issue if there is one, but it can help you respond to it different, which does help train your brain to maybe not pay attention and maybe not wake up to those minor things that likely right now his body is kind of still overly perceptive to, even though he might appear as if he's sleeping very deeply. Does that make sense?
Yeah, would it be just a CBT therapist, or?
I would find a CBT therapist who knows sleep.
Okay.
I'll just jump in a little bit on that too with my neurology hat on, and even comparing it to like an infant, a little baby sleeping, right? They don't consciously, when we go in and out of our sleep phases, we can watch them, those wiggly lines on the EEG when they have their sleep study. When we see them go in and out of deep sleep, a little baby is not consciously waking themselves up out of those lighter sleeps, but just like Dr. Truba is saying, that when there's any sort of attention paid to the sensory experience, or even just fear, anxiety, underlying emotion around, I'm not sleeping, this is bad, I need to sleep, I need my mom to sleep, all of those things that are going to snowball, all of those subconscious things or conscious things are things that will get you out of that light layer of sleep easier. And so by attending to it, even if it doesn't seem like a conscious problem, by unpacking it in CBT and some of these other ways, it's going to then just physiologically help your body be more rested and relaxed during sleep. I think we do a lot, especially in America and Western cultures, of like trying to think our way out of this. And especially for sleep, I think we need to attend more to the physiologic things that make our body relax. And some of that is talk therapy as well, but you know, the breathing, the pain, all of these things, you're looking for reversible physical causes, but we also just need to think about physiologically calming the system, and it's some of this work too during the day that can do that.
Okay. I'm glad you said that, because I'm somebody that if I don't sleep, I start to get mad. And I'm like, I just want to go to bed, and then I get more awake, right? And you're like, you need to calm down. You're waking yourself up. So that's something that I feel like a lot of our guys experience, because they worry about you all, and they want to protect you, and they'll tell me, I don't want my mom to worry. I don't want to bother them. I don't want, right? And so then if you're getting frustrated, that's a very activating emotion, and it's going to be really hard to fall asleep if you're angry and upset.
And we all know that our 2 a.m. self is not the same as our 2 p.m. self. And so spending more time with your 2 a.m. self can get you really, really riled up. And we need a way to unpack that through some of these other cognitive behavioral therapies.
Great, thank you.
I
Sir?
have a question, similar case. My son is 32. He is on a 24-hour volume-controlled ventilator, Trilogy. During the night, he can't keep his mouth shut. So therefore, the ventilator partly bypasses his lung, just blowing out through the mouth again. As a result, he wakes up in the morning with a headache. We've checked O2 saturation, seems normal. So any idea what to do about that? The fact that he can't keep his mouth closed physically.
Well, that is a big problem sometimes when our young men become mouth breathers, and what's happening is the pressure they're getting from their BiPAP machine is coming out of their mouth. So what we sometimes use, and I've used in the past, are like chin straps, just a little strip around the neck that closes the mouth enough, it gives enough pressure the mouth is closed so the air doesn't leak. But it's not so closed that you can't open your mouth and your son can call for help. You don't want it that tight. So just a little bit of a chin guard can help keep the mouth closed and help avoid mouth breathing. Sometimes a different mask interface needs to be done. And a third thing that might want to need to look at for mouth breathing is there nasal congestion that's happening at night that's allowing them to mouth breathe? Do they need to be on a nasal steroid or an antihistamine or something to keep the nasal passages clear? It's a case-by-case basis, but those are 3 options that you can have to go back to your primary pulmonologist and talk about how to improve their breathing at night.
Just a quick question. We have a Tempur-Pedic bed for our son, and I was just wondering, I've heard of other parents that have the hospital bed, the adjustable beds, and I was just wondering if you thought there was a difference and if one was better than the other, or it's a foam mattress too.
So I guess what I would ask you is your son sleeping well in the bed?
Yeah, he is. I just was wondering why so many people have the hospital bed and
I think sometimes people are going to the adjustable bed where the head can go up and the legs can be positioned so that they can, position their child in a little bit more elevation. Sometimes that's for some pulmonary issues. And I mean, the real question is your child sleeping well in that bed? And are you able to change their position well if you need to with that type of mattress?
Yes. But I was just wondering if the quality of the bed is any different. Like it's a hospital bed. I don't know.
No, not really. I mean, you can get adjustable Tempur-Pedic beds as well. It's really what mattresses works for your child. Unless you're getting like pressure sores or something like that, then we would think about different types of mattresses that could relieve that.
All right, great talk. I do have a question from one of our virtual attendees. And the question is, on average, how many hours of sleep is recommended for individuals with Duchenne?
I'll just go down and ask, what everyone's opinion, because My simple answer to that is you have a good night, you have had enough sleep, independent if you have Duchenne or not Duchenne or Becker's or whatever, is if you go to sleep, you fall asleep within 5, 10, 15 minutes. In general, you sleep through the night, you wake up refreshed, and then you function well during the day without the need for a nap or stimulant therapy. Stimulant being a Red Bull, Diet Coke, or anything like that. If you can do all that, you're probably getting enough sleep. So it's a little bit, we have averages, and you showed a picture of what like National Sleep Foundation averages. But those are averages. Everyone's an individual. But if you can fall asleep, mostly stay asleep, wake up fresh, and function well during the day, and not have to take naps, you're probably getting enough sleep. But I'm interested in what you folks have to add.
Yeah, my mind was going to a similar function-based definition of it. I don't know that we have any data to say that there's an additional need to sleep outside of times where there's additional stress. You know, if there's additional medical stress, if there's additional psychological stress, you should be giving your body a little bit more rest and relaxation. I think Dr. Truba alluded to this a little bit. It's hard when we get into cycles where, because there's been a medical stress or because there's been a virus or something else like that, we've built in some naps or other things during the day. Sometimes it's hard to get out of those cycles and back into a consolidated sleep schedule. The consolidation of your sleep is also super important. So it's not the cumulative number of hours in 24 hours, it's actually that consolidated sleep overnight. But in terms of the numbers, I wouldn't give anything different than what you've already said.
I 100% agree with that. I think the other thing is, you know, if you have a younger kid and they're only sleeping like 5-6 hours, I think we want to look into that, right? Because sleep is really regenerative and it's really important for growing and being healthy. And if they're sleeping 15, 16 hours, we would want to look into that. That's a lot of sleep and also not super great for you. So 100% agree with what they're saying about how do you feel and are we getting like quality sleep overnight? There's something else I was going to say, but now I can't remember, so I'll just pass it on.
Yeah, I agree with everything everybody said. I think from a psychiatric perspective, you know, one of those keys of when do we use medication to treat sleep is often when is our quality of life affected. So if we're not able to go to school, do our activities, be at the dinner table with family because we're falling asleep, or if we're impaired in our ability to have like a healthy, successful life, that's when I say, okay, maybe we need a medication on board. And I think it's less about a number, but more about, what are we able to do in the day? And, how well are we able to do it, and how do we feel when we do it?
Claudia, do you have anything you'd like to add? Okay. I would make one comment that we have to keep in mind is the natural evolution of our children is they go from morning kids to afternoon to evening kids. And anyone who has teenagers know that in their ideal world, they go to bed 12, 1 o'clock and sleep to 10 o'clock, which that's fine, but the man tells you got to get to school or you have to go to your job. So we just need to remember, though, that if our teenagers are sleeping later, but they're still getting up at 6 o'clock, they're going to be sleep deprived. So the number in and of itself is not important, but you also have to look at the context, how they're getting that sleep. Yeah, ma'am.
First, thank you all for coming and talking to us about this. So you had mentioned polypharmacy, and my son is, if he isn't on multiple, he has like 4 of those medicines that he's taking for sleep. He doesn't sleep at all. And I'm just concerned, is it all right to be on that many medicines just to sleep?
Yeah, it's a great question. I think, is it okay to be on that many medications? Do we know that kids who have medical complexity are going to be on more medications than maybe a kid who doesn't have a medical complexity? Yes. I think ultimately the answer usually is yes, it's okay, especially if we're not seeing side effects. What I would say and what I would encourage is if we're on for, one of each of those classes that was on the list and we're still not sleeping, that's when I'd say to my doctor, potentially, if these things aren't really working, do we want to pull things back one at a time? And then if we see a change, we know that was helping, and if not, at least we're minimizing whatever side effect might be coming from that medication. Would I say that oh, it's a horrible thing and you need to get them off right away? Not necessarily, especially if we're not having side effects, but I think even outside of a psychiatric realm, if medications aren't doing anything, they're probably only causing side effects or doing nothing, and so they're better off not there. I do find too, on rare occasions, or not even rare occasions, but sometimes as you pull stuff back, you're able to optimize maybe one medication a little bit more instead of having 4 medications that are suboptimal, and then you can get a better response. And so maybe if one medication is higher, we can get sleep, and then you don't need all the other ones. But do I think he's being mismanaged or anything like that? Absolutely not. It's just, if they're not doing anything, potentially trying to trial off of them is not a bad idea.
Well, I guess I don't think they're mismanaging it. It's just, I was just concerned in terms of how they react with other the rest of your body. And how do you define, is it working? Because now he goes to sleep at a normal time. He doesn't stay asleep. He wakes up still. It's hard to get him back to sleep, but he's still sleeping. So I'm calling it a win, but.
Yeah, and I think that sometimes, really with all psychiatric conditions, not just insomnia, I think sometimes you have to have that realistic goal of, this is a win because now we can initiate sleep and we couldn't before. I think very rarely would I say a psychotropic medication sort of solves everything. I think we want it to, right? We want to be able to say this medication is going to help myself, help my kid, help my friend, fall asleep, stay asleep, and have a great night's sleep. I think the reality is that we know that the medications only work so well. And so I would say that, to me, hearing that we're now able to initiate sleep, I think that's an appropriate thing for you to feel like is a win. And I would say that is working then, because sometimes that is the best we can get with a medication. I think when you add in all these other tools that everyone's talked about, right, optimizing our environment, utilizing things like CBT, if we're doing all of those things in conjunction with a medication that can help a little, I think then sometimes we can get to an even better place, but usually the medicine alone is not going to get you there, no matter how badly you want it to, and, that's ultimately what I see happen most of the time.
All right. Actually, the PPMD orchestra is starting to play us off the stage. So I'm sorry we don't have more time for questions, but those of you still have questions, please, we'll hang around for a bit. Happy to take them off mic. And thank you again for attending. Thank you again for coming.